Hi everyone, I'm Dr. Deborah Ristvedt from Vance Thompson Vision in Alexandria, Minnesota. I'm a comprehensive surgeon focusing on cataract glaucoma and oculoplastics. And today we're kind of talking about tougher cases. And I'm going to go through a case presentation and how I manage that and just show you the innovation that has occurred over the time in minimally invasive glaucoma surgery. And so we're going to talk about expanding options in ECP. And so I'm going to start with a 74-year-old female who is referred to our practice. Historically, in her 20s, she presented with pressures in the 40s. And so over time, over the years, she's had a lot of struggle with fluctuating IOP as well as ocular surface disease, really making it difficult to manage her glaucoma. She had cataract surgery 5 years ago in the right eye, and she had a cataract in the left eye. And so we were kind of toying around with, is she ready for cataract surgery as well? But as you will see, her intraocular pressure, despite being on 2 medications in her right eye, again, that was pseudophakic, was 24 millimeters of mercury. In her left eye, her pressure was 19 millimeters of mercury, and that's the one that has the cataract. On gonioscopy, what I saw was occludable angles. But at slit lamp, she had a deep central anterior chamber. And so when looking at that iris, there was distinct draping over the ciliary body as well as the trabecular meshwork, which we'll get back to. And again, on slit lamp examination, I was seeing dry eye, so ocular surface disease, with multiple medication use over the years, as well as a nice IOL implant in the right eye and a 2+ NSC in the left. At this time, I did not see any LPI that had been performed. And this is what her visual field looks like. In the left eye, it still looks pretty good. But you can see in the right eye, we have moderate, encroaching, severe glaucoma. And so we'll delve into what type of glaucoma this is. And so this is a picture of her angle. As you can see, there's that draping over the trabecular meshwork, but then you see another elevation kind of mid-peripheral right by that lens. And so this is called the double hump sign that we see in plateau iris, which is a very common cause of glaucoma. And I think sometimes we don't identify it. But, some things that kind of pointed me towards that where again on slit lamp examination, her anterior chamber was deep centrally, but it was shallow peripherally. She was pseudophakic in one eye, which helped me because, usually with taking out a lens, when you see occludable angles, that angle will deepen, but not in this case. And so despite having an LPI, which sometimes we'll do to diagnose this condition, I knew that we were dealing with plateau syndrome. And so what is this? It's an anterior rotation of the ciliary body. And so what you see is not only that draping over the trabecular meshwork, but you also see another area of elevation, again, in that mid-peripheral area. Usually in the past, we've had medical management for plateau iris. And so pilocarpine has been described to treat this condition to lower IOP, but it does carry side effects with dimming of vision as well as brow pain. And so it's not our favorite medication to go to. She had tried it way back when. I think she had said she was on a medication. She had brow pain, so I'm assuming that's what it was. But that was really our option as well as other topical drops. Now, when we talk about laser management, we still do laser therapy for these patients with plateau iris syndrome. And so argon laser iridoplasty is where we take the mid-peripheral iris and shrink it down to pull that draping of the iris away from the angle, opening up the angle to allow for more outflow. And so this does work pretty well. And as you can see, this is what we did initially. And so our patient's pressure on 2 medications went down from 22 to 17 in the right eye and 19 to 16 in the left eye. So we did get some reduction, but let's take it further. We're in a day of age now where, drops are kind of becoming less first line therapy. We're looking towards SLT. We're looking at minimally invasive ways to treat our patients, whether going to the angle or using different devices to help with not only outflow facility, but also inflow facility. And so that's really the discussion we had. This patient, again, is pseudophakic in one eye, but she's ready for cataract surgery in the left eye. And so we discussed this combination therapy with options. So we had two goals. We had a goal of IOP reduction as well as medication reduction and visual field stability, as we had seen such progression in her right eye on visual field. And so we know when we look at the EAGLE trial, when we look at patients with angle closure glaucoma, if they present with high pressure, we're now navigating through just going right to a lensectomy to deepen the chamber and open up that angle. And so that is a process and a thinking that I always think about, even in plateau iris, where you have, again, draping over the trabecular meshwork. Combination treatments are being done in very different manners. We've seen canaloplasty done with goniotomy. We've seen canaloplasty done with different stents. We can also see combination therapy not only in our pseudophakic patients, but also in combination with cataract surgery. And so for this patient, it really made sense to optimize not only her outflow pathway as we were going to take out that lens, but remember, the right eye has already had cataract surgery and we're still seeing that draping. So what else can we do that's going to further protect her from vision loss? Well, if you think about ECP or endocyclophotocoagulation, we're working on those ciliary processes. And so that is exactly what plateau iris is an anterior rotation of the ciliary body. So if we can use cyclophotocoagulation to help with bringing back the ciliary processes, the angle opens up and we can optimize the IOP reduction by also working in the angle. And this is a video of our patient that underwent ECP with canaloplasty and goniotomy at the time of cataract surgery in one eye and a week later in a pseudophakic standalone procedure in the right eye. And so as you can see, I've already done the cataract surgery. I go back in with this endocyclo probe, which will give us beautiful access to the little ciliary processes. And we know that we're getting enough treatment when you see the shrinkage and whitening of the individual ciliary processes. And so they're shrinking up. So again, with plateau iris, you have anterior rotation, we're shrinking them to pull that angle back. And so right in front of us, we're seeing that the treatment is working. And I really try to sweep as far left and right as I can to get as much treatment. And so again, this is working on the inflow facility of aqueous humor. I usually do this first and then I'll go to the angle because the angle opens up after cataract surgery as well as ECP. And then in this patient, I did a canaloplasty with goniotomy in both eyes. And so this is our patient. Again, she's in her 70s. She's had moderate to severe vision loss in her right eye. And, we just want to hold on to that left eye visual field. And what we're seeing post follow-up was a visual field that's been stable for 2 years, as well as an IOP of 15 millimeters of mercury in the right eye. Again, we started at 22 in our journey on 2 meds and 14 in the left eye on no glaucoma drops. So not only are we trying to optimize the outflow pathway, but we're also thinking about how we can be strategic about maximizing IOP reduction in our devices. And so in conclusion, endocyclophotocoagulation reduces aqueous inflow. It's great for use in combination with other MIGS devices or as standalone or in combination with cataract surgery. It's a great tool for diagnostics. So say you have a patient that has maybe UGG syndrome and you want to look at those haptics. Again, you don't have to do a treatment. You can use your probe to be able to explore in the eye and to get more information that you need. And again, it's effective in really tough to treat glaucoma cases like plateau iris syndrome. And I want to thank BVI for having me. I hope this was helpful, and reach out anytime.